Welcome to Compass Opioid Stewardship in Practice. Each week, our Compass coaches will explore a real-world case, define a clinical goal, and walk through practical strategies to improve care. Whether you're tuning in via video, audio, or reading the summary, this session is built for busy clinicians like you. Enjoy the show.
My name is Scott Weiner. I'm an emergency and addiction medicine physician, and I'm a coach in the Compass Opioid Stewardship Program. Today, we're going to explore how to taper a patient from a high dose of clonazepam. The American Society of Addiction Medicine, ASAM, released a comprehensive benzodiazepine tapering guideline in 2025, emphasizing individualized, slow tapering and harm reduction. Let's apply it to a clinical scenario. Our patient, Andrea, is a 67-year-old woman with generalized anxiety disorder and insomnia. She is taking clonazepam 2 milligrams 3 times a day, so 6 milligrams per day, for more than 5 years, along with citalopram. She requests help because she feels groggy and she's worried about memory impairment from high-dose benzodiazepine use. She occasionally uses alcohol, but denies non-medical drug use. Her hepatic and renal function are normal. She lives alone and she has strong family support. So let's talk about her clinical goals. The goal here is to safely taper Andrea off high-dose clonazepam, minimizing withdrawal and preserving functional status. High-dose benzodiazepine use, which is more than 1.5 milligrams of clonazepam daily or more than 15 milligrams of diazepam equivalents, carries significant risks, especially in an older patient. Therefore, we must follow evidence-based tapering protocols. So how to reach this goal? First, we're going to assess and prepare. Before tapering, evaluate the indications for benzodiazepine use, any co-occurring psychiatric conditions, and Andrea's goals. Use shared decision-making and set expectation that tapering may take months or sometimes even years. We're going to screen for alcohol use disorder. Concurrent benzodiazepine and alcohol increase overdose risk, warranting a slower taper or sometimes even inpatient management. Provide patient education about withdrawal symptoms, which may include anxiety, insomnia, muscle pain, and rarely seizures. Switch to a longer-acting benzodiazepine if appropriate. ASAM notes that some patients may benefit from transitioning to a longer-acting agent like diazepam to achieve a smoother blood levels. Now, this is sometimes called the Ashton method, which you might have heard about before. However, this is not mandatory, and it might be problematic for older adults. Clonazepam has an intermediate half-life, but the smallest tablet, which is 0.5 milligrams, is equivalent to about 10 milligrams of diazepam. In Andrea's case, we can taper clonazepam directly because she tolerates the medication, and a switch to diazepam may actually increase sedation. If we switched, we would cross-taper one dose at a time over 1 to 2 weeks. The next step is to create a tapering schedule. The ASAM guideline recommends initial dose reductions of no more than 5 to 10% every 2 to 4 weeks, with total reductions not exceeding 25% every 2 weeks. For long-term high-dose patients, a slower pace, even like 5 to 10% every 4 to 8 weeks, might be necessary. As we mentioned before, Andrea takes 6 milligrams of clonazepam per day. So 10% reduction would equal 0.6 milligrams. Because the tablets are 0.5 milligrams, we can reduce by 0.5 milligrams every 2 to 4 weeks at first. She would take 1.5 milligrams in the morning, 2 milligrams at midday, and 2 milligrams at bedtime for 2 to 4 weeks for a total of 5.5 milligrams per day. And then we would slowly taper down. First 1.5 in the morning, 1.5 midday, 2 milligrams in the evening for a total of 5, and so on. Once she reaches 3 milligrams per day, which is 1 milligram 3 times per day, slow the taper to 0.25 milligram reductions every 3 to 4 weeks. Avoid reducing more than one dose at a time. Give her body a chance to adjust. Additionally, and this is very important, provide non-pharmacologic support. Collaborate with behavioral health to treat any underlying anxiety using cognitive behavioral therapy, mindfulness, sleep hygiene, and physical activity. SSRIs or buspirone may help anxiety during the taper, and for insomnia, melatonin or trazodone can be considered as well. Encourage avoidance of alcohol and stimulants, and ensure that the patient has a single prescriber in pharmacy and schedules regular follow-up visits. And of course, we're going to monitor and adjust. Check for withdrawal symptoms or resurgence of anxiety at each visit. If Andrea experiences intolerable symptoms, pause the taper or step back to the previous dose until the symptoms are resolved. Always consider harm reduction strategies such as prescribing naloxone if opioids are co-prescribed or if she has risk factors for respiratory depression. So let's go over some helpful tips again. Always start slow. Reduce the dose by 5 to 10% every 2 to 4 weeks. Avoid reducing more than 25% in any 2-week period. High doses, so again, more than 1.5 milligrams of clonazepam per day, warrant extra caution because of diazepam dependence and withdrawal risk. And you can also consider switching to diazepam for smoother tapering, but cross-taper 1 dose at a time over 1 to 2 weeks. Use a slower pace at lower doses. Once you get to about 1/3 of the original dose, make reductions of 5% or 0.25 milligrams of clonazepam every 3 to 4 weeks to minimize withdrawal. And always use behavioral therapies and non-diazepam medications to treat the underlying disorder, that reason for why the patient might be on benzodiazepines in the first place, and improve the success of her taper. Importantly, tapering benzodiazepines is a marathon. It's not a sprint. Following the ASAM recommendations and tailoring the plan to the patient's needs increases the chances of success. The Compass Opioid Stewardship Program provides clinical protocols and patient education tools to help guide transitions like this. For personalized technical assistance, reach out to me or any of the other clinical coaches to schedule a coaching session. The clinical pearls we want you to remember are: again, do not reduce the dose by more than 5 to 10% every 2 to 4 weeks. Go slow. This is a race, but any reduction in dose is a protection against harm. And then always remember to treat the underlying reason why benzodiazepines were started in the first place.
This show has been brought to you through the generous support of the Centers of Medicare and Medicaid Services. Thanks for joining this week's Compass Opioid Stewardship in Practice. Thank you for being part of the Compass Opioid Stewardship Program, and thank you for all you do caring for your patients. See you next time.